Dear colleagues, and thank you, Ibrahim, and good morning, everybody, and thank you for inviting me to the 6th LAA global meeting. I have the opportunity to speak about the use of the ICE. Really, my presentation is propedeutic to the next presentation, in which Eric Nielsen will show a practical case of LAA closure procedure using the ICE. The transesophageal echocardiography is, of course, widely the most common tool used for guiding the procedure, but it needs of general anesthesia and is more discomfort for the patient, and it requires more time in the use of the cath lab. And the ICE is, in my opinion, a good alternative to the use of the TEE. What we want to know from the ICE, basically, we want to know exactly the same thing that we ask to the TEE. We need to have good information about the Fossa Ovale's view in order to do a safe and effective septal puncture, to have information about the anatomy and the dimension of the LAA in order to select the right device for that patient. And we need of a tool for guiding the placement of the device. But probably the more complex step is to rebuild in our mind a 3D complex structure like the heart, starting from a 2D view. This is a common concept to the TEE. In the next slide, I will try to show you my experience with the ICE and several steps that could be helpful to use the ICE for the LAA closure procedure. This is the technology available today. We have two devices. The first is for Biosense Webster Siemens, and the second from St. Jude. Basically, the technology applied is the same. All the devices are steerable in 4 directions: anterior, posterior, lateral right, lateral left, or composition of these 4 basic positions. The main difference from the TEE is the point of view of the structure. The TEE is placed in the esophagus and see the LAA from this view. The ICE usually is placed in the right atrium and see the LAA from a different point of view. So the anatomical landmarks could not be the same, and sometimes it's not possible to overlap the projection that we have, that we get with the TEE, with the image that we have the ICE. Some steps to understand the correct use of the ICE. The probe is advanced from the right or left, basically it's the same, femoral vein, through the inferior vena cava. The first image that we see is this one. We are at the level of the liver and just below the right atrium. You keep the probe in neutral position and you advance the probe at the level of the right atrium. When we are at this level, we have to rotate the probe in order to have in front of us the tricuspid valve. And this is the ICE view in this position. You can recognize the right atrium, the atrioventricular valve, and the right ventricle. From this position, if you turn gently clockwise, you have this view. You are in front of the aortic valve and the pulmonary vessel, and this is the ICE view from this position. You can recognize the aortic root, the pulmonary, the right ventricle, at the right atrium. With a fourth clockwise rotation, you are in front of the Fossa Ovale. You need to tilt posteriorly the probe in order to centralize the imaging, and you will get this imaging from the ICE. This is the corresponding view. You see the Fossa Ovale, the septum secundum, the left atrium. Usually this view is very good because the probe is just in front of the Fossa Ovale and close to the Fossa Ovale. And this is fine to perform a good transeptal puncture. This is an example of transeptal puncture. You see the tenting in the inferior part of the Fossa Ovale, but you need to do the puncture in the inferior posterior part of the Fossa Ovale. So I suggest to turn clockwise the probe in order to explore the posterior part of the Fossa Ovale, or if you need of a view, antero-posterior view of the Fossa Ovale, do the same steps. Go back to the home view. Rotate counterclockwise the probe and orient the probe to the right side of the patient. When you see the crista terminalis, you move posterior the catheter, and you will have the point, the tip of the catheter just in front of the coronary sinus, just below the tricuspid valve. From this position, you see the septum from the lower part, and this is the similar imaging from using an MR images for a vector comprehension, and this is the view of the septum vallis from the anterior to the posterior part. But one of the problems is how to visualize the LAA. There are a lot of positions that we can use to visualize the LAA. The first and the most useful, of course, is from the right atrium. From the Fossa Ovale position, you manipulate with the right and the left position in order to get a good imaging of the LAA. It depends on the spatial orientation of the LAA. You can advance the probe in the mild coronary sinus, or you can advance the probe in the pulmonary artery, or if you want, in the left pulmonary artery. We recommend to start for the classic projection from the right atrium. This is the corresponding ICE view from the right atrium. You can see the right atrium, the septum, the left ventricle, the LAA, and you see here the coronary, the circumflex coronary. This is a good view to visualize the appendage, and you take the measurement. This projection is similar to the right cranial projection in the angio. You see very well the ostium and the landing zone, and in our experience, we find it a good correlation between these two measurements in order to select the right device for that patient. This is a failed test, stability test. You see the migration of the Amulet from the landing zone to the right atrium before the release, and this is the ACP well placed in the ostium of the left atrial appendage. But if sometimes the view of the LAA from the right atrium is not fine, because if you are working with patient with a large left atrium, you can miss the detail. We suggest the original projection advancing the probe in the left atrium just in front of the LAA. This projection was described by Claudio Tondo and his co-worker some years ago, and this is very original projection, and this usually you can get really a good information about the LAA. The probe usually is in this position at the ostium of the left superior pulmonary vein or at the ostium of the LAA. And this is the corresponding view of the LAA. You see the LAA during microbubble injection, the catheter, and the circumflex artery. The problem is how to get the left atrium with the probe. We have two options. The first is to perform a second transeptal puncture, but this is more traumatic for the patient. And the second is to keep the wire that you used after the transeptal puncture in the left superior pulmonary vein and manipulate the probe and advance the probe in the same hole that we used for the transeptal puncture. Usually it's not complicated, and from this position you can keep the catheter just in front of the LAA or in the proximal part of the left superior pulmonary vein, and you can follow all the procedure. You see the position of the lobe of an amulet. You see the circumflex artery, and this is the device after the complete release. I want to conclude my presentation with a few slides about the 3D ICE. The concept is completely different because with 3D ICE you acquire a volume, and the volume size is an important concept because the imagined wide is in lateral dimension, azimuth, and elevation, and the penetration. These are all the technical characteristics of the volumetric acquisition. And the second point, the second concept is the volume rate. That is the volume, the number of images per second. This is the view using a 3D ICE from the left atrium. You see the ostium, you see the mitral valve, and this is the corresponding to the view. And this is an amulet during the placement, during the stability test. You see the lobe during the traction, you see the disc during the traction, and the lobe well placed inside the left atrial appendage. My conclusion is that the ICE is a safe and effective alternative to the TEE, but my presentation, I saw before, is propedeutic to the next presentation of Eric, in which we will share a real case from the theory to the practice. Thank you very much for your attention.